Welcome, I'm Barbara Marcum, and this is Health Matters. With me today is Dr. Bryan Coniglio. He's with Rheumatoid Associates, and tell us a little bit about the background because we have some personal history. I was diagnosed with something, systemic gout. I didn't actually have that, but I went on prednisone, and when they took me off, I couldn't walk. So they gave me a list of rheumatoid doctors, and all the way down they said, oh sure, and this is, keep in mind, the end of January. Well, we can see her sometime in April. And I'm thinking February, March, April. So I got down, here, Corey, my son, was actually calling, got Dr. Coniglio's office, and he was explaining to the receptionist what had happened. She said, hold on for a minute. She said, can you be here at 11:15? We'll be there, yes. So I met Dr. Coniglio during that visit. We had blood tests and we talked about gout and blah, blah, blah. He said, well, I need to do blood tests and figure out what we're gonna do. I'm not telling you the things I'm gonna test for first because you're gonna go home and you're gonna go on the computer and you're gonna freak out. So I'm not gonna tell you anything. So let's find out what's going on with you. So with that, I think probably 4 or 5 visits, and then we were talking about markers. So that's why in my whole career with the city, I have never done a show on inflammation or autoimmune diseases. This gave me a whole nother perspective. I mean, not only like when you said, well, you have a little arthritis, but it's normal for your age. Nobody really wants to hear that, but it's true. So I wanted to do this, and I think there are a lot more people, and I just actually met 2 people who were just diagnosed with lupus. So I wanted to do this show because I've never done it before, and I think it affects way more people than I first imagined, and me being one of them. Out of the middle of nowhere, being a healthy person all my life, when I saw you, I couldn't even walk. So with that, thank you, Dr. Coniglio, for being here today. Let's talk about inflammation and autoimmune diseases. Let's talk about first, how do you determine what a problem is when somebody first comes? When you see the blood work, what is it that you're looking for?
Great. Happy to be here.
Good.
So I'm a rheumatologist, so I specialize in joint diseases. I also specialize in a lot of autoimmune diseases. I see people for a lot of undifferentiated joint pain, and we use a lot of these blood test markers, we call them serologies, antibodies, markers of inflammation, to help in a diagnosis. But it's not just the blood tests. Just sitting down and figuring out what's going on, getting a history, taking a look at your joints is equally as important as what the blood tests show. And kind of adding them all together is what can help me make a diagnosis, but sometimes blood tests are helpful, sometimes they're not.
What made you decide to go into this field of study, out of curiosity?
I always enjoyed puzzles when I was a kid, and so when I was going through training, I discovered that a lot of these diseases are like solving a puzzle. A lot of times it's a mystery, the disease doesn't always present in the same way, and so you have to kind of put your thinking cap on and figure things out. And like I was saying, we use a lot of different things, history, exam, blood tests, imaging to help figure it out, but sometimes we still have to figure it out because it's not always the same.
Can still be a puzzle.
Yes.
Like my particular case, we're not really sure. We think it may be stills. I will tell, I've always been an open book with this community, always. So when we were looking at markers, okay, after my blood work, we were talking, what is normal inflammation? You said like 5. And what is mine? 3,000. It was like 3,000. And then it got me really nervous. And then the ferritin levels, you said what's normal? It's like 0 to 100 or 30 to 60, whatever, right in that span. And it's like, well, what's mine? 14,000. That was a really scary moment for me because I thought, well, number one, I don't know what ferritin is, but I didn't like the fact that 14,000 was way higher than 100, right? So what is it that when you look for something, when you look for serious diseases, these markers, what are you looking at the blood work when it comes back into you?
Yeah, so ferritin is one of multiple different markers of inflammation. The two most common ones are actually something called ESR, which stands for erythrocyte sedimentation rate, and CRP, which is C-reactive protein. Those are probably the two most commonly used inflammatory markers across all fields of medicine. So those ones we use. We also use ferritin, which is an acute phase reactant. It's a marker of stores of iron in your body, but when there's a lot of inflammation going on, so specifically systemic inflammation, it will be elevated. Elevated is usually 1,000, maybe upwards of 3,000, not 14,000. That's very high. That's usually indicative of something very severe inflammation going on.
There was some very severe inflammation, but let's talk about inflammation in itself. What is the difference between acute inflammation and chronic inflammation?
Primarily just the duration of symptoms. So acute inflammation is going to be a process that's going to occur for a couple days, upwards of maybe a couple weeks, and then it's going to resolve. It may come back, it may be episodic and acute, but it's usually going to not last for more than a couple weeks. Whereas chronic is something that's going to last weeks, months, even years. It also can be episodic and flare, so get worse at certain times, but it's not going away. And unfortunately, that's the nature of a lot of my autoimmune diseases. They are chronic inflammatory conditions.
Okay, so what are some of those conditions that you see the most of that are autoimmune diseases that are, I'm not going to say fairly common because I don't think they're common, but what are the ones that you see the most?
Yeah, they're actually quite rare. The most common one that we see, rheumatoid arthritis, probably only affects about 1% to 2% of the population in general. It's probably the most common autoimmune disease across the board, but there are other ones, specifically in rheumatology. We see a lot of patients with psoriatic arthritis, lupus. These are the more common ones, but there are other diseases as well outside of rheumatology: multiple sclerosis, psoriasis, type 1 diabetes. These are all types of autoimmune conditions.
Okay, so I guess my question from what you said, like, what do they have in common? I mean, is it that they affect different parts of the body? Are they caused by different things? What are some of the causes, and do we know that?
A lot of times we don't. We think of the cause of autoimmune disease as kind of multifactorial, and honestly, we as rheumatologists still don't really know the exact cause. We see a higher prevalence of autoimmune disease in females. We see a higher prevalence in patients who have autoimmune family history, so other members of their family with autoimmune diseases. But there's not always a specific gene that gets passed down, so it's not like you can just do a genetic testing for specific autoimmune diseases.
Can there be other causes other than like a genetic factor? Like environmental, maybe?
Environmental, there's certain triggers, a lot of times environmental. We don't know. It's a very good question because a lot of times we don't know what causes it. We know how to diagnose it, we know how to treat it, but we a lot of times don't know the cause.
That's interesting. Okay, so like between lupus and some of these other bigger things that you didn't want to tell me about. Okay, so like if there's, how do you treat autoimmune diseases in the same way? Like when I was on a steroid, I had a very, very bad reaction to prednisone. Okay, and I mean, to the point, it's like, did you gain any weight while you were on the steroid? And I said, no, actually I lost 25 pounds. I couldn't eat, I couldn't sleep, I'd go to bed about 10 o'clock, and by midnight I'd be up, wide awake, and could not sleep. So, are most of these things treated with steroids, or are they treated in different medications?
It depends on what the manifestations are.
Okay.
A lot of my autoimmune diseases, so meaning ones that we see in rheumatology, they're going to cause joint inflammation, and steroid prednisone is an anti-inflammatory that's very quick in onset, very helpful. Unfortunately, has a lot of side effects, not necessarily something we want to use long term, but in a pinch, it's very helpful to get things under control, honestly, within hours or at least within a day or so. We have a lot of other medications that we use other than steroids, but a lot of times steroids is one of the first initial medications, and you're not the only one who has a lot of side effects to steroid. I don't like giving it out, but sometimes it's very necessary because we're looking at very debilitating symptoms otherwise.
Well, and you said that, it's not, I'm sorry to have to give you a steroid, but it's the only thing that's going to help you right now. So even though, now, what about steroids? Are there people with conditions that have to stay on steroids for a long period of time? Or do we try to make that as short as possible?
So in the past, we used to use steroids a lot more than we do now. Now we have a lot of newer drugs, what we call disease-modifying anti-rheumatic drugs, to more or less take the place of steroids. We call them steroid-sparing agents because they do the same thing that prednisone does, but they're much safer long-term.
What do you consider long-term, like over a month or two, like for years, on and off kind of thing?
Years.
And there are conditions that last that long.
When we're treating chronic inflammatory conditions, we're looking at years.
Okay, when you're talking about inflammation, what are the signs of inflammation?
So most common outward signs, meaning what we feel: pain, swelling, warmth, redness, but there's a lot of parts of inflammation that are going on behind the scenes that we never feel or even a lot of times know about. Inflammation is a normal physiologic response in the body.
To injury?
Injury, illness, any kind of perceived threat. You think of a virus or a bacteria, we want that fought off. We don't want to get sick, and it's our immune system that helps us do that.
I'm curious about the arthritis. I mean, a lot of people have, what would you call regular arthritis that is part of the aging process?
So that's osteoarthritis.
Okay.
As people get older, have used their joints more, cartilage wears down, you're more likely to have osteoarthritis or wear and tear arthritis, degenerative arthritis. And that's very different than an autoimmune inflammatory arthritis.
Like rheumatoid arthritis?
Like rheumatoid.
What is psoriatic?
Like psoriatic,
okay.
like Still's disease.
What do they, Still's? Okay, that's what we think I might have.
Yes.
Okay, so what is the difference in the arthritis? Does it look the same in the joints?
No.
Okay, what is the difference?
So in inflammatory arthritis, like rheumatoid, for instance, the most common, it's the synovium, which is a tissue inside our joints that actually is getting inflamed, and that's what's causing all of the symptoms. And so that is very different than our regular osteoarthritis, regular old arthritis. That is when the cartilage, that cushion in between our joints, breaks down over time. Now, symptom-wise, it can be similar. Pain, swelling are going to be similar symptoms in both. And severity, honestly, you think that inflammatory arthritis is more severe, and a lot of times it is in the moment, but osteoarthritis can be very severe too.
Sure, I can understand why. I met somebody the other day, and they had some kind of procedure done where they scraped out the joint instead of having like a replacement. So is that something that's fairly new or no? Or
no?
And what do they use to go in there and do that?
So that's orthopedic surgeons who are doing that. Not in my field, but they're more or less using their equipment. It's arthroscopy to clean out the joint. They could say scrape out the arthritis to try and help prolong the use of that native joint. A lot of times they'll do that to prevent having to do joint replacement surgeries.
When I first went in to see you, and I'll never forget this the first time, well, why don't we just go ahead and drain this knee? And I said, no. No, I'm not having needles in my knees, no. And by the next time I was ready, it was very painful, and you said, I can give you a little bit of relief here. What causes fluid to build up in a joint like that? I mean, I can see where it's inflamed, I can see where it's hot, okay, or warm, but where does the fluid come from?
It's all just the irritation, the inflammation inside the joint. It produces all that fluid, and we call it an effusion, a joint effusion. And as the fluid builds up inside an otherwise smaller joint capsule, it gets quite painful because it doesn't have anywhere to go.
well, that was my situation, but I will tell you, as much as I hate needles, it wasn't terrible. I thought I was pretty good with all of that.
Fine.
But I mean, how often does that happen? Do you see a buildup of fluid? I mean, obviously you do that a lot because you were very good at it. Okay.
Thank you.
And I didn't want to do that at all. But after the prednisone didn't take away a lot of the swelling in the one knee, it was like, but there was joint fluid in both of them. So, I mean, I guess my question is, does the fluid build up in the joint? Is that common? Do you see that a lot?
The more severe the arthritis, so especially an inflammatory arthritis, the more severe the inflammatory arthritis, yes, very common. An osteoarthritis, it's usually not as severe. The pain is more chronic, mild, and so fluid can still build up, but it's not to the same extent that unfortunately you were dealing with.
Yeah, that was a lot. Okay, so there were some things that I looked up on the computer that I thought were very interesting. What is Addison's disease?
Addison's is an autoimmune disease of the adrenal glands, so an endocrine autoimmune disease. So not something I treat in rheumatology, but one of, honestly, many different autoimmune diseases.
And what is lupus?
So lupus is a systemic connective tissue disease. It's something that we do treat very commonly in rheumatology. It affects the joints, it affects the skin, it affects a lot of organs in the body.
Connective tissue.
Yep.
Would that be muscles, or I mean, what exactly is everything?
Unfortunately, yes. There's connective tissue in a lot of the organs, and so it can affect the heart, it can affect the kidneys, it can affect the brain. It is a true, what I'm going to call systemic or whole body autoimmune disease.
I'm glad I didn't look that one up because I know you tested me for that.
Correct.
For sure. Yeah, that sounds like probably the worst out of all of these if it can affect everything.
It is one of our, unfortunately, worst autoimmune diseases that we treat, yes.
And what do you have to avoid? Like, how do you control that?
I mean, we use prednisone, similar to what you got, and we have other medications to take the place of prednisone and that have been found to be very effective for it, thankfully.
But that's something, if you're diagnosed with that you have to be treated for life, is
Yes.
that correct?
Yes.
Okay, and does it come and go, or do you basically have it all the time, or are there flare-ups with that?
Nope, it very commonly flares, will come and go, and we try and keep it controlled as much as we can, and we don't want it to flare.
No, but do we know what causes the flare, or not really?
In autoimmune disease, a lot of times we don't, but stress is very common as a trigger. Infections are very common as a trigger of autoimmune disease, meaning both in the diagnosis of it, but also what can help make them more active, unfortunately.
When you say that they're like infections, what kind of infections can do that?
Any kind. Your regular upper respiratory infection, your virus, a cold, COVID, anything.
Yeah, it's interesting because I have a friend who's kind of a conspiracy theorist, right? She said, I know somebody else who had an autoimmune disease and they tested her for cancer and she went through everything for 2 years. It's that COVID vaccine. Did you get one? I got 2, actually. But I don't think we know anything about that as far as this goes.
Not at this time, no.
Okay, have you seen a rise in autoimmune diseases?
Not necessarily. I think at the beginning of COVID, and I don't know if this was just a coincidence, I was attributing it to the increased stress that everyone was under, and I was diagnosing a lot more diseases at that time, but I don't know if that's a coincidence. I don't think there's any evidence to show that is true. But I think over time, and I'm not talking about me specifically, but we as rheumatologists are seeing them become more common, and we don't 100% know why.
That makes sense.
I think maybe we just have better means of diagnosis, and so we can test for them, find them earlier. We have better ideas of what they are. A lot of times things were more undifferentiated, right. And now we have names for these undifferentiated diseases.
That's really interesting. So I know you like to put together puzzles, which I can see. Now, after going through all of this myself, how it would be really elimination.
Sometimes
Right.
diagnosis of exclusion is sometimes the wording we use. There are certain common presentations and certain things that are not.
Okay, when you look at like a blood test and something like that, okay, so say you said we talked about there are like maybe 3 different things that you look for one thing, and you may not have all 3, you may have one of the 3. What does that actually mean when you're looking at things? Because I think there was something that you said about, you might have this, but only one marker, or it was something, and I can't remember exactly what it was. But when you look at markers, like say for rheumatoid arthritis, do you have like all 3, or are there certain things, or do you combine them to get what you are looking for?
So we've got markers or serologies as well as autoantibodies.
What is a serology?
So it's a substance, biological substance that, not me personally, but we have found to be indicative of someone with rheumatoid arthritis. So meaning it has been studied, this is, in the past has been studied and found to be elevated. So it's a biologic substance that's been elevated in patients who have a diagnosis of rheumatoid arthritis, and now we can use it for subsequent patients to help us diagnose.
Okay, so when you're looking at that, that's one thing you look at. What are some of the other things? Because when you were talking to me, just as far as the ferritin and the inflammation markers, I'm thinking, what are you looking at, and what did you look at that didn't show anything?
So they're just as helpful to rule out diseases.
Okay.
So meaning when I first saw you, I did a lot of blood work, a lot of testing. Pretty sure I called you up on the phone and told you more what you didn't have,
Yes.
more so than what it was, because I'm using them to both diagnose and then also rule out. But there's certain clinical, we'll call it like a clinical picture of this, that, and the other, meaning certain symptoms that are going to help me when I'm trying to put together this puzzle and solve it, going to help me rule things out, rule things in. This is what I'm doing when I'm asking you questions, when I'm first getting to know you and trying to evaluate things. Like I said, it's more than just the blood work. It's really trying to put the whole picture together. And there are certain things that will stand out for rheumatoid arthritis. There's certain things that stand out for psoriatic arthritis, particularly a certain joint pattern or a history of psoriasis is going to help lead me more towards a diagnosis of psoriatic arthritis versus rheumatoid.
Do you think that there are a lot of people who live with certain conditions for years and years?
Yes, unfortunately.
Okay, so who do you think, under what circumstances and what symptoms, if there are people out watching the show, when do you seek out some professional help? What do you look for if you're having symptoms? What kind of symptoms would lead somebody to an office like yours?
So rheumatologist, I would say joint pain, but especially joint pain that's associated with inflammation, whether you can see it or feel it or not. But I like to tell people when something just doesn't feel right. So a lot of times you know your body. In fact, you know your body better than I do. And so you know when something's just not right. Is this just my typical arthritis? I moved too much today, it hurts, that's why I hurt? Or is something else going on and it's just not going away? That's what I would advise you to reach out. Probably a good place to start would be talking with your primary provider, talking with them. You can always see a rheumatologist, especially if it's more joint related, but at least figuring out is something going on is probably the first step.
Yeah, when I ended up not being able to walk, they said, this is inflammation, you need to see a rheumatoid doctor. And it was like, and the fact that most of them took 12 weeks to see, that for me was like, that's not doable. I mean, I can't even walk. So the thing that really, it's like when they said this is inflammation, I don't know how they knew that, but I can tell you I went from being a normal person to literally being an invalid in 3 days. So for me, it was like, can you be here at 11:15? We are there. Yes. So I thought that was really great. Okay, so when you have, so you work with other rheumatoid doctors. Do you ever have to consult with each other?
Yes.
And it's probably a really interesting room when you're talking about all the different stuff.
I mean, we're trying to figure out a lot of times what's going on, and so just having other thoughts and other opinions, oh, I've seen that before, or I've never seen that, can be quite helpful.
Yeah, 14,000. You told me I've never seen ferritin 14,000.
That is what my partners told me.
Yeah, well, that was really interesting. Okay, so the possibility of genetic factors for autoimmune diseases, and I mean, like, I have nothing in my family ever. So the environmental triggers, I was reading some of this, stress infections, hormone imbalances, immune system dysfunction, and this was the shocker for me, 80 known autoimmune diseases. 80.
Believe that.
So it's like, you hear the common ones, the lupus, Addison's, multiple sclerosis. What is that and what causes that? Do we know what causes it? No. What are the symptoms of that?
Multiple sclerosis can be a neurologic one, so a lot of times it's weakness, particularly in extremity. That's probably one of the most common causes. And a lot of times your PCP will probably direct you more towards a neurologist than they would me, because the symptoms fit more with a neurologic disorder. Yeah.
Okay, so, because that surprises me. So you would notice weakness, would that be muscle weakness? Okay, and okay, so this is the other thing that I was reading about, is that the different autoimmune diseases affect different parts of the body.
Correct.
So that neurological would be one thing, right?
Yes.
Inflammation would probably be the joints.
So inflammation is that's true for all of them.
Oh, okay.
They're autoimmune. It's the immune system more or less attacking itself, mistaking our own tissues and organs for something foreign and causing inflammation. So it can occur in the endocrine system, in our glands. It can occur in the neurologic system, our brain, our nerves. It can occur in the joints. So a lot of my diseases almost all affect the joints as well as other organ systems.
Well, what are when you see a patient, okay, and I know you see him for the first time, like you said, there's a lot of blood work that's involved. Okay, so when you see the swelling and things, that could be fluid in there.
Yes.
And that's common. Will it go away on its own? Or
if it's acute, sometimes it will. It'll just go away. It'll resolve in a couple days. The flare resolves, and the acute inflammatory reaction is past. Whether or not you did anything for it or not, it will go away on its own in certain more acute inflammatory conditions.
All right, if you have inflammation, is it best to treat that with heat or cold? I'm curious.
When it's active and it's painful and swollen, ice will probably work more acutely.
Okay, because I was curious about that. I never did ask you that question, but I thought, should I be doing something with this? And I thought, well, I know somebody who has like rheumatoid arthritis. She goes, sometimes heat feels better, sometimes cold feels better. It's like whatever works for you.
Heat can be helpful too, but ice is probably where I go first.
Yeah, no, I would say so as well. Okay, so what are the most interesting things about what you do? I know you put the puzzle together. I know I had x-rays and I had blood work and I had all of those things. You think that I may have Stills. What is Stills exactly?
Stills is like an autoimmune disease. It's actually called an autoinflammatory disorder, so a different part of the immune system involved. But it more or less follows the same type of symptoms as other autoimmune diseases. It's just treated differently.
Okay, so with me, I remember you saying to me, your inflammation will probably come back. It's not a matter of when. I mean, it's
not
a matter of
if,
yeah,
but,
it's not a matter
but
of
probably
if,
when.
Probably when. So, I mean, I'm sure I will be seeing you again very quickly. But with the Stills, there's an injection that you can get, right?
Yes.
And that keeps it at bay. What exactly does it do to keep it at bay?
So it's more or less taking the place of prednisone. So it's working as an anti-inflammatory like prednisone, but prednisone's attacking all forms of inflammation. This is specifically attacking the specific cytokine that's more active in Still's disease.
Do you think I have been a big proponent of exercise with seniors. I know wear and tear is an issue, but I also feel that the benefits of exercise, and you can do some exercises that are not as hard on your joints. Do you think that this is a good thing for seniors to do, or do you think it may cause inflammation or problems to occur?
So I'm a huge proponent of being active, of exercising, but doing it within your means, meaning
Reasonable.
don't cause more harm than good. But exercising, being active, and this is as simple as just walking, can be very helpful for our joints long term, both from osteoarthritis as well as from inflammatory arthritis.
You know, I did notice that. Like when I was staying at Corey's for 2 weeks because I really couldn't do anything. That would be sore when I first got up because I'd keep my legs straight. But then when I got up, and I was on the prednisone at the time, but it was like walk it out. And then I'd walk for a while and it would get better and better. So I think, you know, like especially behind the senior center in Westland, they have a beautiful walking track that's 1/6 of a mile. People can come. It's in pine trees and it's got lots of shade. People walk around there 6 times as a mile. And even if they start out slower, it's, I think, a good thing for everything. Circulatory system, their joints, their everything.
Yep.
Is there anything that people can do, like to lubricate? I know you told me this one thing. What should I use on it? I tried the Voltaren. It worked really well as far as that goes. Is there anything that anybody can, drinking water, does anything help lubricate the joints, or anything that you can do to help save your joints?
That's a good question. It's a question unfortunately I'm asked a lot.
Because you probably see the bad stuff.
And a lot of times there's only so much we can do. You know, arthritis in the joints is caused by overuse, it's caused by injuries. Some of these things we can't prevent, but being active, being healthy, eating a healthy, clean diet, these are all ways that we can help, to the best of our abilities at least, try and prevent the onset of arthritis. And this is more of the osteoarthritis variety. It's unfortunate, but you know, autoimmune inflammatory arthritis is going to happen sometimes whether or not we're the most healthy person or the unhealthy person. It's going to come on, and like we said earlier, we don't exactly know why all the time, but it's going to come on, you know, irregardless of this. But you can still do all these things to keep yourself healthy.
Yeah, I think diet has a lot to do with fresh fruits and vegetables and staying away from highly processed foods.
Yes.
You know what I mean? Now, I was big into seafood, which I told you, trying to stay away from red meats, but really trying to do away with the carbs. So, yeah, that's why when I was diagnosed with gout, you said, maybe it is. You added all these different foods to your diet, which really wasn't part of my diet then. But, yeah, so it was hard to figure out, but I'm certainly glad that my path led to you, because you made it more a comfortable thing and answered all my questions. And even though it was kind of a scary thing to do for me in the beginning, especially when you said, I'm not going to tell you the bad things, you're going to go look them up and freak out. It's like, what? So anyway, I appreciate, and I didn't understand inflammation, autoimmune diseases, and you answered so many of my questions and didn't hurry me, and I had all kinds of things that I was absorbing that you were telling me. So I really appreciate all of your time and all of the information, and I'm sure I'll be seeing you probably sooner than later. But Dr. Coniglio, I thank you for being on the show today and giving a perspective to inflammation and autoimmune diseases. So thank you so much for being here.
No problem.
And thank you, friends in the viewing audience, for being with us today.